Step to the Future 1 كانت البداية، وكان أول مؤتمر للجمعية المصرية لزراعة الأسنان، واتعمل في اسكندرية سنة 2018. كان مؤتمر جميل جدا، ونجاح المؤتمر ده خلانا نفكر إننا نعمل تاني مؤتمر 2019 Step to the Future 2 اللي كان برضو نجاح منقطع النظير. وكملنا بعد كده بستيب تو ذا فيوتشر 3 اللي اتعمل سنة 2020، وكان الحمد لله نسخة أنجح من النسختين اللي قبله كمان، وحضور كان كبير جدا. لكن بسبب الكورونا اضطرينا ان احنا نتوقف لفترة، ورجعنا لكم تاني بستيب تو ذا فيوتشر 4 سنة 2024. لكن النسخة دي كانت اونلاين، وكانت في شهر رمضان الكريم، وكان معانا سبيكرز كتير جدا. نجحت قوي النسخة، ودخلنا في 2025 ستيب تو ذا فيوتشر 5 وبعدد اكبر من الدكاترة، وعدد اكبر من السبيكرز، وعدد كمان كبير من السبونسرز والشركات اللي بتجيب لنا هدايا. واخيرا السنه دي ستيب تو ذا فيوتشر 6 سنه 2026 في رمضان ده، منتظرينكم تتفرجوا على المحاضرات. كورس الزراعه بتاع الجمعيه المصريه لزراعه الاسنان بدا من سنه 2006، يعني بقاله دلوقتي 20 سنه، يعني يعتبر اقدم كورس يمكن قائم لغايه النهارده في مصر. الكورس ده في محاضرات، وفي نظري، وفي ورك شوبس وعملي، يخلوك قادر ان انت تشتغل معظم حالات الزراعه اللي بتيجي في العياده عندك. بتدرس من اول انترودكشن وكل حاجه، وتريتمنت بلاننج، والسيرجيكال بروتوكول، وبيشنت سيلكشن، والسوفت تيشو مانجمنت، هارت تيشو اوجمنتيشن، والبروسيسز والكومبليكيشنز والفيليرز. وكمان بتشتغل بايدك على بيشنت، يعني انت بتتدرب على كل حاجه، بلس مجموعه من الورك شوبس. مش هتطلع من الكورس ده الا وانت ان شاء الله عارف تشتغل كويس. آلاف الدكاتره اخدوا الكورس ده معانا، وان شاء الله ربنا يقدرنا والاف تانيين هياخدوا الكورس. يلا تعالى جوين الالاف اللي هياخدوا الكورس معانا.
مساء الخير وكل سنة وانتم طيبين، رمضان كريم. معاكم دكتور محمد سلوم. اهلا وسهلا بيكم في النسخة السادسة من مؤتمر Step to the Future اللي بتقدمه الجمعية المصرية للزراعة. في البداية بنحب نشكر سبونسر محاضرة النهاردة، وهي شركة دينتال كامب، على دعمهم الدايم للمحتوى العلمي. وكمان حابين نفكركم إن معانا النهاردة 8 جوائز، وهي 1 implant from Sidra Dental, 1 Edita 1H from Endodent, 4 Seal Mate Sealer from ToothMate, 2000 كوبون ديسكاونت from Dentalize Academy، و1 Box Splash Irrigation Needles from GoDent. وكل اللي عليك تعمله انك تعمل شير لللايف، وتعمل منشن ل5 من اصحابك. وكل ما تعمل منشن ل5 مختلفين في الكومنتس، كل ما فرصتك في الفوز تزيد، وهيتم اعلان الفائزين بعد المحاضرة. يشرفنا النهاردة وجود دكتور اسلام قاسم، واللي اكيد هنستفيد جدا من خبرته ومحاضرته القيمة. اهلا بيك يا دكتور.
اهلا بيك يا دكتور، اخبارك ايه؟ كله تمام؟
الحمد لله الحمد لله تمام. حضرتك تقدر تبتدي.
اوكي ماشي. السلام عليكم. مبدئيا بحب اشكر دكتور احمد حليم على الدعوه الكريمه. بصراحه انا بشتغل معاه من نقدر نقول 15 سنه in all the events he do it all over the world, and a lot of dentists they benefit dramatically from his passion in education, especially in dental implants. My topic today about trigeminal nerve injury, which is very very important for safety, and I think nobody can work without knowing the basic knowledge how to evaluate the injury, how to avoid, and when to refer. This is my brief resume. I am oral maxillofacial surgeon with special interest in facial aesthetic, and currently I serve as an examiner in the Royal College of Surgeons of Edinburgh and Glasgow. This is my team in Alamein Hospital. This is our specialty, oral maxillofacial surgery. To be a competent oral maxillofacial surgery, you should be familiar with 10 specialties, starting from dental implants, extractions, pathology, apnea, cleft, wisdom removal, injury, trauma, and jaw surgery, and facial cosmetic surgery, and finally TMJ. I don't have any conflict of interest in these lectures. In this lecture, I discuss the anatomy, and then what's happened during the injury of the nerve, how we classify the injury. This is very important to know your limits and whether it will improve or not, to know the prognosis, how we diagnose and how we can manage, and finally, how we can anticipate the outcome. Trigeminal nerve, it's a cranial nerve number 5. It has 3 divisions: ophthalmic, maxillary, mandibular. Our basic work, usually it's related to the maxillary and mandibular. And also, we have some related dental anatomy, like inferior dental or inferior alveolar nerve. And we have the foramina here. If you can palpate, it's called mental foramina. The direction of the mental foramina changed dramatically. So for dental implants, very important to notice the anterior looping. Also, we have the buccal branch of the mandibular trigeminal. You have to take care, especially when you're making your incision. Lingual branch, it's in the lingual mucosa of the lower first and second molar, so you have to take care to avoid problem. This is the anatomy of the inferior alveolar nerve. Here, the inferior alveolar nerve. This is a mandibular nerve. We have a 3M, masseter, mandible, medial trigoid. So this is mandibular canal with the nerve. Also, we have the vein and artery. This is what we call it neurovascular bundle or VAN. We have here nerve to the mylohyoid, which is very important. In some case, during extraction or during doing the procedure, you have to give numbing. You have to enter your needles lingual to the mandible to give numbing to the nerve to the mylohyoid, which is supplied mainly by innervation of C2 and C3. This is a supply to the teeth, and this is a mental nerve, mental foramen, supplying the area of the chin. So usually I like to assess the numbness of the patient to check if I have numbness here or numbness here anteriorly, and also I have to examine whether the patient can differentiate between 2 points. So I tell my patient, you can differentiate between here and here or no difference. This is very important during diagnosis. This is the ophthalmic, and this is mandibular, and this is maxillary. If you notice from the embryology, we follow exactly what we call it, the embryology thoughts. This is the nerve affection. So if you have any nerve affection, I encourage you can mark it on the patient and you can see, and this is useful for seeing the improvement. This is how to, if I remove the wisdom, like this case, this is a shadow of the canal. Another important tip, I prefer to make my incision not above the bone directly. I prefer to make it slightly buccal. Why? And I don't like to, the aim of the need of the blade just to remove the mucosa. Why? If you do too much medial, you have the risk of injuring the buccal nerve. The patient tell you, doctor, I have numbness from the inside of the cheek. This is if you numb the long buccal cheek. Another things, as I told you, when we do extraction, it's a gentle lady skills. You don't like to get too much aggressive force. You have to do it neatly as you can. Nerve injury in dentistry, it's common, most common nerve injury. It's significant quality of life and increasing also the medical legal implication of the patient. Like this deep case. If you see this deep case, this is how can we do luxation gradually, time by time. I don't like to make injury of my nerve. And this is how to remove it. The most common cause, it can be caused from some patient, they can get long anesthesia, local anesthesia. The patient tell you, doctor, I have prolonged anesthesia after I finish the procedures. The anesthesia lasting for 1 or 2 days. So one of the important things I tell my patients, especially after I give anesthesia, please take care. Don't bite your lips. Take care, don't eat your lips. And if the children, there are beautiful stickers called Watch Me. I can put it for the kids if you are doing pediatric dentistry. We can see it in the third molar, even for the endodontic, especially for over instrumentation. I will share some cases of endodontic injury with you. It could be mechanical trauma, especially if you're working without irrigation, toxicity, ischemia by giving too much anesthesia with adrenaline, compression. Some people, they prefer to do over crushing. So after extraction, you're doing over crushing. They can make some injury, especially for the lingual nerve. Like this case, this is super deep. Here, if you see the canal, we monitor the canal. For this case, we're removing the roots using a bezosurgery. Bezosurgery, it will cut only in the bone, and it will not go inside soft tissue, and it enable you of decent removal. This is a nerve. So another advice, when you remove, don't removing very fast. You have to irrigate, and you have to dissect the root from soft tissue. Why? Because in some case, when you remove it, you can make a avulsion of the canal. This is a nerve. If we go and have some deep dive in the anatomy, this is the nerve. Nerve is surrounded by, it's not continuous. We have something that's called nodes of Ranvier. This is the neurovascular vein. It's containing the vein and artery, and this is the fat, and this is the vesicles of the nerve. To make access of the nerve, especially when we make some nerve lateralizations, we can opening and we can dissect, like in this case. We have several types of injury, starting from neuropraxia. Neuropraxia, some injury from, usually we see it after doing surgery by some edema. The patient tell you, doctor, I have complete numbness, and it will improve with 1 or 2 days. Axomatosis or neuromatosis, you get complete cut. The worst complication is neuroma. It's healing by granulation tissues. And the patient tell you, doctor, I have severe pain, and they have something called dysesthesia. Patient pain will be continuous pain without painful stimulus. If we have nerve injury, we can repair it by some microneurosurgery. We are going to discuss. This is the shape. This is how the nerve looks like. Nerve fibers, it's containing by something is called endoneuron, and we have something is called perineuron, and we have something epineuron, the main vesicles. Okay, this is a nerve. Another important tip when you're doing dental implants, especially in the lower areas, I advise you, either you are using guided injections, guided placement, or you can using your 2 hand. Put your hand in the surrounded for the mandible, and using stopper. I know it's very basic, but I remind myself and remind you about these important tips. This is what's happened if you have neuroma, and this is how we repair it with 10O sutures. When you're doing microsurgery, we have rules. It's called rule of 10. To enter the microsurgery or micro repair, you have to using 10-0 in 10 minutes. You have to do 10 sutures if you're able. So we can have some access of you doing some training in animal lab. This is a background. We use it to repair. The management, this is algorithm based on Seddon et al. We have several types of nerve injury. The first degree is called Seddon classification. We have it's from transient ischemia, and it's segmental demyelination. It's due to intravascular edema. Usually it will resolving in 1 week. You have to decreasing edema. How we can decreasing edema? Some operator prescribe some steroids. Personally, I prefer to using hot fomentation and using low-level lasers. Second degree, it's axon, it's intact, and there are some injury in the epineurium, if you remember the epineurium, and usually recovery, it will take some weeks. Third degree injury, it's involving epineurum and variable, and nerve exploration, it's maybe considered, maybe, not sure. Fourth degree, you have the injury, it's involving the epineurum and perineurum. How can I detect? Can I detect with a CT scan? A CT scan can show me if there are a hard tissue, but MRI will be more accurate. Fifth, if you have a complete or injury, microsurgery is indicated. Usually it's presented with paresthesia, dysesthesia, anesthesia, or neuropathic pain in some cases. This is from dental implants. Sorry. Okay. Another important thing, and we see it from the people that are doing root canal treatment, by especially with Thermafil. So if you have any complication like this, and the patient come to you with numbness, either you can extract or you can removing the root canal and making irrigations. You can make irrigation with aggressive irrigations and keep the keeping irrigation. Usually irrigation is done with some steroids. Neuropraxia, it's called mild nerve manipulation or traction. It's compression injury. It's characterized by reversible condition. The patient tell you, doctor, I have complete numbness, and it will improve after 1 or 2 days. Okay, the nerve is intact. Axomatemesis, it's involving the axon damage. The complete recovery, it can lasting up to 12 months. So if the patient tell you, doctor, there are any problem, and I feel numbness and I have a slight minor improvement, okay, I assure him and I tell him it can lasting up to 1 year to get complete recovery. This is neuropraxia, you have injury in the upper limit, and for axomatemesis, you have injury in the nerve. Neuromatemesis, the injury in complete or near complete nerve transections. It's including the epineural discontinuity. So in this case, is unlikely to have a spontaneous recovery, and it will need some surgery to be repaired. We have several classification system. The most common is Seddon and Sunderland classification system. It's based on histological finding. We have 5 degrees, like we stated later on. Nerve healing. We have several sequence of nerve healing. It could be something like by degenerations. It's mean demyelination of the dissolved in the isolated segment. So the patient will, doctor, I have a neuropathic pain. In this case, you can prescribe some medication for neuropathic pain. We have Wellren degenerations. It's in the axons. It's occur in nerve transections, likely to undergoing spontaneous regenerations. Regenerations, especially if the patient is healing, is good. This is the regeneration is possible when you have a continuous pathway. So, for example, if you have the implant here and the nerve is cut here, it will never repair. So you have to remove the implant. If you have a root canal inside it, so you cannot repair. This is a neurolemma. It's absence of absence in nerve. So we have to get it together to enabling fasting here. Neuroma, it represents disorganized mass. It's collagen fibers. It's disorganized, and it's central or fusiform neuromas. You have different things. It could be central. It could be lateral, like this. It will involving in a huge pain. So you have to remove it surgically and resuturing the nerve together if you have nerve. Any things we make sutures, we have to respect the biology. So we have to work without tensions. A detailed history you have to notice, and you have to use some specific neurosurgery. You have to do pain questionnaires. I prefer to use VAS, starting from 0 to 10. Neurosensory testing, we can use some heat, some static light touch, some directions to know exactly. I prefer to use my non-toothed forceps to patient differentiate there are a 2-point or 1-point. So this is algorithm I follow in my diagnosis. This is the direction of 2-point of discrimination. It could be normal or abnormal. Abnormal, you can go in the upper level. Mildly impaired, you see the patient repair, and you can using some anesthesia to check if the patient has a real injury. Usually we have to evaluate, we have to make a sheet of what's happened in the patient. If you have neuroma or neuropathic pain, we can prescribe some rapid anticonvulsive agent like clonazepam. This is from the Egyptian market. It's from Apex. I prescribed for 2 weeks. It's very helpful to decreasing the pain of my patient. At the time of symptoms, usually we classify the injury. It's immediate or delayed, transient or permanent. We diagnose with neurosensory examinations. We ask for imaging. For medical legal reasons, I prefer to ask for a medical CT, not cone beam CT scan, because I will have some report with it. We make neurosensory testing, light touch, 2-point discrimination, prick by probe, or I prefer to use insulin syringe. Let's see the lingual nerve. We see it a lot of injury, especially when you are going to extract the wisdoms or even the lower teeth. So one of my advice, I prefer to dissect to have a mucobuccal dissections, and also I can put either some periosteal elevator to guard against the lingual push and pushing the my instrument to have some injury. This is a hypoglossal. This is a tensor vili. Usually we have some people during extraction, if you are tell the patient opening too much, you can some injury in the tensor vili. So the patient tell you, doctor, I have some pain during deglutition or swallowing. This is lateral pterygoid muscles. So one of my advice, I asked my patient to open the mouth till rotation and mild translation, not full translations. This is a lingual nerve. And this is a hypoglossal nerve here. This is a genioglossus. Okay, we have some risk factor like anatomical variations, surgical difficulty due to difficult access, experience level, and usually by repeated injections. How we can do preventive strategy? By proper technique, anatomical awareness, and informed consent of the risk factors. Like this horizontal case. Usually I like to follow this in my flap. I like to put my releasing incisions here. And this is how I dissect. I prefer to make it a complete mucoperiosteal flap. Here I don't like to go too medial. Why? Because I'm afraid from long buccal nerve. I prefer to have using mesosurgery for more safety. This is separation. You have to be considered when you remove the roots. Why? Because in some removal of the roots, you can have some tethering and you can get some injury of the nerve. This is how to remove it. I have my trick during the sutures. I prefer to get it from down to up. So I eliminate the infra-bony pocket related to extraction of the wisdoms. Like this case, this is an old case. Another same scenarios. This is how can I make my incisions, my flap. I make it from here to here. And I prefer to use Vicryl 3O or 4O. See, there are no releasing incisions even if you do it like this. And during the sutures, don't make it too deep. Why? Because in some case, you can make some traction to the nerve with sutures. What's our management? Number one, you have to recognize if there are any problem. You have to reassure the patient. You have to document. And you have to refer if there are injury from type 4 or type 5. Like this case. Here, this is near the nerve, like this. Pharmacological management, we can give some steroid. I prefer to give a short-term, short-onset steroids. Non-steroidal anti-inflammatory is very, very crucial. Why? Because I don't want my patient to get in a vicious circuit of the pain. In some cases, I prescribe some neuropathic agent. For non-steroidal anti-inflammatory, I prefer to prescribe Profen 800 milligram twice daily, once for one time. It's sustained retain. Surgical management, we indicated if there are we have to discuss the indication of the referral, how we can do microsurgical repair, and the timing is considered. Surgical management, if you have complete cut of the nerve, so you have to refer the patient immediately. Okay, complete anesthesia. There are no residual sensations. If you have type 4 or type 5, no improvement after 3 months. You have, if you see the nerve injury with your hand, with your eye, we see it several times during the parotid surgery or during some implant surgery, some trauma surgery, and we're able to repair it. Contra indication if you have improvement, so no need for surgery. Lead dysesthesia, central neuropathic pain. It's something central. Trigeminal neuralgia, anesthesia dolorosa. What's the meaning of anesthesia dolorosa? The patient tell you, doctor, I have numbness, and when the patient tell you, you have pain. Microsurgery, it's can I do it in my clinic? No, I have to take my patient under general anesthesia to get complete cooperative. We have to dissect, and we have to exposures, and we have to do some sutures. This is some approach to do it. We can do osteotomy, or we can do like PSSO or exposure. Personally, I prefer to using rim to expose the nerve. You can see the nerve and you can repair it. I have some trick. After I finish repair or I finish manipulation, I using PRF to enhance my healing. This is the cartoon, show the company we do it. You just put the nerve together, and it's not my cartoon, and nerve, it will repair with timing. You can take some nerve graft. In some cases, especially if you have some root canal treatment and it will go outside, you can do some irrigations. Neuromas, you have to excise to improve the healing. This is how to excise the neuroma. And we make using 9O or 10O using microscope to repair it. We can put some background with some technology. We can use it to repair it like this. We can use some hyperbaric oxygen or some technologies to enhance the healing. Indirect repair, we can take some graft. Recently, we have access to the cadaver nerve. You can get the nerve ready-made instead of taking from the cadavers, like this case. Okay, some research support the value of it's by Google articles, and these articles, it will support the healing and improving the patient quality, like this case is my case. The prognosis depend on the severity, depend on the persistent symptoms. If you have less than 6 months, you can report, but after 6 months, the result is not so good. Okay, early improvement. Okay, medical legal, it must be considered. You have to do proper consent, you have to do clear documentation, and you have to do early referral if there are. I advise you to using a cone beam CT scan to study your cases well, to know the nerve, to know your limitations. This will improve your work a lot. This is how can I plan my case with Dr. Amr Tuhami, how we study the wisdoms, we study everything, we study the relation of the roots. And I think every dentist now has access to the cone beam CT scan for proper things. Let's see some cases. The inferior alveolar nerve injury, symptoms for more 2 days. Diagnosis, it's injection-related neuropraxia. It will improve spontaneously, not for intervention. We prescribe some steroids like prednisolone. There are a need for vitamin B or some vitamins, no need. There are no evidence support this. Another case, injury in the nerve. Third molar extraction, lingual nerve paresthesia post-extraction. The patient come with altered taste and texture. For this case, we refer it for maxillofacial surgeon. For this case, I am going to make my incision. I dissect and I removing the granulation tissues, and the patient will improve dramatically. This is a case. Here, it will show the injury to the nerve here. Okay, it can come from injury to the using implant. Facial nerve also, we can repair it with several techniques, like in this case. We can harvest some fasciolata, and we can harvest it to the orbicularis oris muscle. This is how to suspend it. Thank you so much for your time. And the take-home message from my lectures: prevention is very crucial. Very crucial. Early diagnosis, which is very important, and you have to know when you refer and when you assure the patient to get a good outcome. Thank you so much for your time, and if you have any questions, I'll be more than happy to answer.
Thank you so much يا دكتور.
كورس الزراعة بتاع